Welcome. Hello to those joining us online and to everyone here in Seattle. I'm honored to welcome you to the second plenary session of the 39th Annual North American Cystic Fibrosis Conference. In just a moment, I will introduce our distinguished plenary speakers who will deepen our knowledge and our understanding of how we can improve the lives of people with cystic fibrosis. Before we move to do that, I'd like to acknowledge some truly extraordinary individuals in our care center network. I will start with the Bonnie Ramsey and Richard C. Talamo Distinguished Clinical Achievement Award, presented to those whose careers have profoundly altered the course of CF care and research. It's a privilege to stand before you today to recognize a true pioneer in the field of pediatric medicine and CF research, Dr. Phil Farrell. Dr. Farrell's journey began with a moment of compassion and clarity during his third year of medical school, when he encountered an 8-year-old girl hospitalized with CF. He got to know her well and unfortunately watched her die. On that day, Phil committed to doing what he could to prevent such deaths in other children. Over the past 4 decades, Dr. Farrell has transformed that commitment into groundbreaking action. His path was cemented when Dr. Harry Schwachman pulled him aside at a conference in 1975, commented that newborn screening was the only hope for early diagnosis, and said, "Phil, as a neonatologist and CF Center director, you should be the one to advance the field." And aren't we lucky that he did? His leadership in the Wisconsin Cystic Fibrosis Neonatal Screening Project, initiated in 1984, demonstrated unequivocally that early diagnosis through newborn screening paired with aggressive nutritional intervention could prevent malnutrition and significantly improve outcomes for children with CF. Thanks to Dr. Farrell's vision and dogged persistence, every U.S. state and the District of Columbia now screens newborns for CF. And as many of you know, his persistence knows no boundaries, so that children with CF all around the world benefit. His efforts have not only changed clinical practice, but have also saved and improved countless lives. As a tireless advocate for quality improvement, he organized the National Quality Improvement Consortium. He partnered with the CDC to develop a CFTR mutation repository and helped establish best practices for CF newborn screening. Since 2007, he has served as the Cystic Fibrosis National Facilitator for CF newborn screening and quality improvement, ensuring that the promise of early diagnosis is matched by excellence in care delivery. On a personal note, Phil, I want to express my deep gratitude for the partnership we've shared over the years. When I joined the CF Foundation 9 years ago, you graciously welcomed me into the fold and supported me as I deepened my understanding of CF newborn screening. Together, along with many others in the audience, our partnership has helped advance health equity in CF newborn screening, and for that, I'm sincerely grateful. I'm also grateful to your family, and in particular, your wife, Alice, for sharing you with us. Alice, Phil asked me to express his gratitude to you for the support, patience, and love you've given him for over 60 years. It won't come as a surprise that Phil is accepting the award on behalf of the entire Wisconsin team. Go Badgers! The team has worked together for 5 decades to develop improved methods of early diagnosis. Phil, today we celebrate not only your scientific achievements, but also your unwavering dedication to the CF community. Your legacy is one of compassion, innovation, and relentless pursuit of a better future for children with CF. Dr. Farrell, on behalf of the Cystic Fibrosis Foundation, your colleagues, and the countless families whose lives you've touched, it is my great pleasure to present you with the Ramsey Talamo Award. Congratulations and thank you. Now, I will hand the microphone to my colleague, Paula Lomas, who will present the next awards.
Hello. The Cystic Fibrosis Foundation's Mary M. Kontos Care Champion Award is presented to 2 members of the multidisciplinary care team who have made significant contributions in the field of specialized CF care. This award honors the memory of Mary's passion for excellence and commitment to improving the lives of people with CF and families through exceptional care and advocacy. Our first recipient worked alongside Mary Kontos for many years. She is recognized for her leadership, tireless work ethic, clinical acumen, and her heart of gold. Her center director notes that her commitment to people with CF in clinic, in the hospital, and in the moments of life in between is unmatched, making her a lifeline for adults with CF. One adult said, "There were times when I was struggling and things didn't look so great. But having her there assured me we would get it through things, and it kept me positive and always looking forward." A long-standing and active member of her center's mental health team, she led efforts to improve access to mental health resources for people with CF. Nationally, she has enhanced the role of the advanced practice provider in CF care delivery. I am proud to announce that the first recipient of this year's Mary M. Kontos Award is Dr. Lynne, certified physician assistant, doctor of physical therapy, and the Adult Cystic Fibrosis Program Coordinator at the Cystic Fibrosis Center of Western New York. Our second recipient is an accomplished pharmacist, author, and educator with exceptional teaching abilities, mentoring the next generation of pharmacists in CF care. She's a pioneer who is establishing a pharmacist patient-centered model of care at 2 CF programs. Her dedication to improving processes and the patient experience has resulted in the implementation of modulator therapies, the development of medication monitoring tools, and greater efficiency in planning for and monitoring exacerbations. A parent said she was calm in the middle of what felt like a really big storm. I am thankful for her expertise, communication skills, enthusiasm, and commitment to helping my daughter make it through the worst time of her life. I'm pleased to announce that the second Mary M. Kontos Award goes to Hanna Phan, clinical professor and clinical pharmacist specialist at University of Michigan. Lynne and Hanna, all of us thank you for being champions of care for our community. All right, do it again. Please join me in welcoming them to the stage to receive their award. That's great. The Carolyn and C. Richard Mattingly Leadership in Mental Health Care Award is given by the Cystic Fibrosis Foundation each year in recognition of leadership and commitment to the mental health and well-being of individuals with CF. This award is a tribute to the Mattinglys and their inspiring devotion to people with CF through the promotion of emotional wellness throughout the CF community. This year's recipient is a leader in the CF community, both locally and nationally. Her patients wrote of her kindness and compassion as she helps them navigate their emotional journey through adulthood with CF, helping them to develop strategies for coping with stress and anxiety. A teammate notes, her passion for the mental well-being of people with CF is exemplified by her daily interactions with her patients and her CF team. And her commitment to advancing care is seen by serving on multiple committees. On a national level, she's brought mental health into the conversation by serving on the CF Education Committee, the Post-Transplant and CRMS CF SPID Guidelines Committees, and she is currently a member of the CF Mental Health Advisory Committee. And you can thank her for helping co-author many of those mental health resources that we have produced. I am excited to announce that this year's recipient of the Carolyn and C. Richard Mattingly Leadership in Mental Health Care Award is Dr. Lily Christon. Lily is a licensed psychologist and associate professor of psychiatry and behavioral sciences at the Medical University of South Carolina. Please join me in welcoming Lily to the stage to receive her well-deserved award.
A huge congratulations and thank you to our award winners. We're just so fortunate to have such a dedicated group of CF care team members. To everyone nominated, thank you for the incredible work you do every day. Before we move to the plenary, I'm deeply saddened to share the passing of one of the Cystic Fibrosis Foundation's founding parents and a transformative leader, Doris Tolson. Doris turned her love for her daughter, Annie, into a lifelong mission that dramatically improved the lives of people with CF, in part by galvanizing support for essential CF research and care. Our hearts go out to her family. Now, it's a privilege to introduce this plenary session, A Breath of Fresh Age, Redefining Growing Older with CF. Just a few decades ago, the idea of aging with CF was frankly unimaginable. But today we are witnessing a profound shift in outcomes thanks to data-driven care delivered holistically by multidisciplinary care teams, equipped with transformative therapies, and supported by the relentless advocacy and resilience of the CF community. This session is not just about celebrating longevity, it's about redefining what it means to live well with CF across the lifespan for all. As more individuals with CF reach far beyond adulthood, we face a new question. How do we support aging bodies in what was historically considered a childhood disease? Our speakers today, Drs. Ahmet Uluer and Karen von Berg, bring deep expertise to these questions. They'll explore the realities of aging as well as opportunities to innovate as people with CF grow older. Spoiler alert, it isn't all about innovation. It's about each of us, care team member and individual with CF, putting into practice the knowledge and data we already have in our possession. Most importantly, our speakers will help us reframe aging not as a limitation, but an opportunity. A new frontier in CF care, one focused on thriving and not just surviving. It's a distinct honor to introduce Dr. Ahmet Uluer, Director of the Adult Cystic Fibrosis Program and Bridges Adult Transition Program at the Brigham and Women's Hospital and Boston Children's Hospital CF Center. He also serves as Assistant Professor at Harvard Medical School. Dr. Uluer earned his undergraduate degree from the University of Michigan, his medical degree from Kansas City University of Medicine and Biosciences, and completed his residency in internal medicine and pediatrics at the Cleveland Clinic, where he also served as chief. He went on to complete a fellowship in pulmonary medicine at Boston Children's Hospital and has been working as an adult pulmonologist at Brigham and Women's Hospital since 2006. A nationally recognized leader in adult CF care, Dr. Uluer has dedicated his career to advancing transitional care models and improving outcomes for individuals aging with CF. He's joined today by Dr. Karen von Berg, a distinguished physical therapist at the Johns Hopkins Cystic Fibrosis Center, where she provides care to both children and adults with CF. Dr. von Berg earned her Bachelor of Science in Physical Therapy from Northeastern University and her doctorate in physical therapy from Utica College. She serves as the co-facilitator of the CF Foundation's CF Physical Therapist Mentoring Program and is a Partnership Enhancement Program facilitator. With over 2 decades of experience in CF care, she has been a leading voice in advancing the discipline of physical therapy in improving respiratory health, mobility, and overall quality of life for individuals with CF. Today, she brings her deep clinical insight to the evolving conversation on aging with CF. Ahmet will kick us off. Please join me in welcoming him to the podium to help us redefine what it means to grow older with CF.
They say, like, dim the lights. Whew, this is happening. I am humbled to be here today. And so on behalf of Karen and I, we are grateful to Faro for his kind introductions, and to the amazing Whitney Brown and Quinn Tran and Mike Boyle, who was my first mentor when I came out of the gates as an adult CF program director. And I also want to recognize my amazing wife, Deb, and my boys who have only shown me kindness and patience. And I also wanted to just say something about my dad, who was an old school doctor who I lost earlier this year. And I want to especially say thank you to Olivia, Jess, and Jose, and the NACFC Plenary Planning Team for this opportunity to speak with you, knowing just how many amazing people out there they could have asked. And as I was talking to people this week, I was thinking about people I would have asked to do this. And at the end of this, you might say they should have asked, but I hope not. This plenary presentation on redefining growing older with CF, a subject I'm passionate about, is made possible through the dedication of those of us who got us here, the commitment of you in the audience and listening online, but especially the resilience of the cystic fibrosis community. The fact that we're here to continue to speak about aging with CF reflects the decades of progress in science, clinical care, and advocacy. I mean, all of it. And I want to express my gratitude to the individuals and families who entrust us with their care, and to also take a moment to acknowledge those who are no longer with us, but whose legacy shape our work today. And it's in their honor and the future of everyone with CF today that we gather here to address the opportunities and the challenges of growing older with cystic fibrosis. So our holistically interconnected systems, and made up of the CF community, researchers, clinical teams, underscore how we all depend on each other. And to realize the goals set forth in the 1950s by those families who are getting together to begin that path to finding a cure. And the great side effect of all that innovative and expert care that our pediatric colleagues out here in the audience made possible has resulted in the largest number of adults with CF and counting. People with CF are functioning and breathing better, and this welcome side effect isn't only for those on modulators. And though we recognize this progress isn't celebrated in every corner of the world yet, that will come. Conversations about properly caring for adults, starting with the first adult program back in the 80s that I just learned about, paved the way for all these other milestones you see behind me, and leading to the plenary delivered by the amazing Liz Tullis back in 2022, and now us. So let's take a closer look at the numbers and the changing face of CF. In just over 20 years, we can see the growing number of people from age 40 to 50 as depicted by the bottom two bars, and how a group of people between ages 30 and 40 went from the 4th largest cohort to the 2nd. In response, the CFF registry now reports out additional data important to adults like blood pressure and lipid, and showcases our growing number of people over the age of 50 since 2023. The CF Foundation Registry is a living document that tells us a story. And one such story includes women with CF who historically have had shorter lifespans than men. But that gap between the sexes is closing. And though we still need to better understand the reasons for it, there are now more women than men over the age of 60. Now, aging science has gone mainstream, with the media almost daily shedding light on what helps us live longer and healthier, and often for a hefty fee. And maybe they're just targeting me because they think I'm getting old, and I'm getting a lot of those, and I'm interested. But there's only one single message to take away from all of that noise, just one: exercise. Exercise and movement is still the single most important answer to the question, how do we slow down aging? And almost as important, there's personalized nutrition and medicines and restorative sleep, stress resilience. These all shape how we age. And for those with a history of chronic illness, this field offers not just curiosity, but crucial tools to decelerate the aging clock. And these tools often converge on one central theme that was shared last night: inflammation and our immune system. We all know the role of inflammation in CF. We've been fighting it together for decades, and we're always looking for that next best anti-inflammatory. Inflammation is a principal driver of aging and the age-related comorbidities in the general population, and here are some of the most common comorbidities, which are also relevant when talking about accelerated aging and what we plan to slow down in CF. There is atherosclerosis, or damage to the blood vessels around the heart involving inflammation. Cancer isn't usually life-threatening unless it spreads, and our immune response can stop that from happening. If it wasn't for inflammation in the brain, we wouldn't see dementia or stroke develop. And when our immune system engages in self-directed attack on our own body tissue, we may deal with joint pains like in CF-related arthritis. Now for a quick refresher. This might take a while. And I wish Jim Schmiel was in the house to come up here. And I'm sorry he was not able to be here to help me explain this slide because he helped create this. So let's erase that slide. I'm just kidding. Recently, actually, a non-medical family member asked me this really tough question. He said, what is inflammation? And so I had to figure out how to put it simply. The immune system coordinates both pro-inflammatory and anti-inflammatory responses. We need inflammation. It's essential for defending the body against injury, but it must be tightly regulated and balanced by anti-inflammatory processes to restore and maintain homeostasis. Otherwise, excessive or unresolved inflammation can lead to tissue damage and premature aging in CF. There's a book called Super Agers by Eric Topol, who just happened to be one of my teachers and mentors from residency. He outlined 5 themes, or he's still outlining 5 themes. He's on a bunch of podcasts, managing inflammation and aging. We will focus today on immunity and lifestyle, while also touching on medicine and vaccines. And there's so much to say on the topic of artificial intelligence, and we heard about it at the TDN conference, but we will leave the role of AI for another day and hope you got to see some of the sessions on the use of AI in clinic. That was yesterday. So actually, Lisa Kunze and Stephanie Craig did a great job. So reading their manuscript, you've got it all figured out. You don't need to listen to this. But much of they conclude is, once again, a consequence of inflammation and the wear and tear of living life with CF. Hear that a lot. Think of it like a fire that never quite goes out. It keeps smoldering and damaging tissue. There is damage to DNA as inflammation directly releases toxic molecules that chip away at our genetic material. And that raises the risk of cancers in areas where inflammation is most prominent. There's a protein stress. Misfolded CFTR proteins clogging the cell's recycling system can spark even more inflammation. And then there's the powerhouse of our body, the mitochondria. It burns out and it fuels inflammation once again. Stress cells stop dividing but don't disappear and release more of these inflammatory signals, and the body's repair efforts just get exhausted, while enzymes break down lung tissue, leading to scarring and stiffness. We will talk about telomeres shortening in a minute, but all of this woven together pushes aging more quickly in CF. While not a complete reversal of inflammation, some of the drivers that we just showed, and these are 3 of them, just mentioned, are positively impacted by correcting CFTR with currently available modulators for those who are eligible. And some examples of how modulators help reduce inflammation includes a study by McNally and Rosenfeld and others, observing infants ages 1 to 4 months participating in an open-label ivacaftor study. And this study revealed its positive impact on immunoreactive trypsinogen, a marker of inflammation of the pancreas, and fecal calprotectin, a marker of inflammation in the gut. And there are many other examples that include ivacaftor and its role in reducing inflammatory proteins like IL-8 and IL-1 beta in sputum and IL-6 in blood. Another study by Einerson and Tunney and others observed an association between ETI and reduced levels of several other cytokines and chemokines, and those are the molecules that I've already mentioned that enhance inflammation. And there was a session just yesterday by Eamon Mullen on this same topic. But this is where inflammation comes to life for everyone, telomeres. There are other predictors of biologic age called phenoage, or an even more precise one called grim age, although I don't love that name, which is associated, by the way, lots of CEOs out there, they're checking their telomeres all the time. That's on their little list of labs that they check. But telomeres are still the most recognizable, so we're going to do a quick lesson. Telomeres are specialized structures made of repetitive DNA sequences or oligonucleotides, along with special proteins that are dangling and capping the ends of these chromosomes. Imagine the plastic caps at the end of your shoelaces, and these are called aglets, preventing the shoelaces from unraveling and needing to be replaced. So it's just like that. And these caps similarly protect chromosomes from damage and from mutating, but with each cell division, these telomeres shorten. They shorten by chronic stress, inflammation drives this, and which leads to telomere dysfunction and cellular aging. Think of telomeres as your biological clock for those cells, and their gradual shortening over time is a key process in aging and the development of chronic disease. All right, hitting closer to home for some. Stress experienced by resident physicians, particularly during their first year of training, leads to increased systemic inflammation and accelerated telomere shortening. Longitudinal cohort data show that first-year residents, so if you're a first-year resident, close your eyes, and for everybody else who are physicians, it's too late. It's too late. Up to 6 times the typical annual rate of telomere attrition compared to population norms. And you can see the other population norms there. And this effect is directly associated with the higher workload and longer work hours and lots of sleep deprivation. So we got to watch that. And as well as markers of inflammation like C-reactive protein and CRP. In a study of 168 people with cystic fibrosis with longitudinal data available for just over half of them, we see progressive decrease in telomere length as well. They especially, by no surprise, decrease associated with exacerbations, and in men more than women, and also associated with mutations that are consistent with greater disease severity. Now, a message for everyone in the audience, and it's going to change the way you behave. Observational and interventional studies consistently show that vitamin D deficiency is associated with higher levels of inflammatory markers such as CRP, IL-6, and TNF-alpha. And in this observational study with just over 1,000 participants, it should come as no surprise that your vitamin D levels were associated with longer telomeres and further modified by calcium intake. I mean, I would tell other people to take vitamin D, but I wasn't taking vitamin D until I read this article. The shortened telomeres associated with low vitamin D are thought to represent a 3-year difference in life expectancy, and that's huge. So how do we tackle all of this? Great care is never the work of one person, and I want to give a shout out to the amazing pediatric and adult CF team at our combined Brigham and Women's Hospital and Boston Children's Hospital CF Center. Can I hear from you guys? Thank you. That was great. And I can't do this talk alone either. So please help me welcome to the stage my friend, a brilliant physical therapist, and a human being who I am thrilled to share the stage with tonight is Dr. Karen von Berg.
Thank you. Before I get started, I'd like to give a shout out to the peds and adult teams at Hopkins. I would not be here without your support. Thank you. Likewise, to the CF physical therapists who I've learned from and with over the years. You guys are the best. To my husband and my 3 girls who are home, well, some of them are home in Maryland watching from the family room and one watching from the dorm room in Jersey. Thank you so much for putting up with me for the last few months getting ready for this talk. And to the people with CF, including those we've lost, I'm humbled by how much you've taught me and extremely honored to be part of your care team. My journey in CF began when I started at Hopkins in 2000, shortly after our adult program got started, and when most of our role as physical therapists was focused on airway clearance and generally promoting an active lifestyle. Who knew that 25 years and 24 NACFCs later, I'd be standing on this stage talking about aging with CF. It's been so wonderful working in both the pediatric and adult clinics to get to watch our patients grow up, to grow older with them, and to be with them as they transition to adult care, begin careers, build families, and explore new decades of life. Since 2000, my role as a PT has evolved and expanded. We've learned so much about the complications beyond the lungs and the pancreas that become even more critical as people age. Now, I used to think of CF, the complications, and all the treatments like pieces of a jigsaw puzzle. You need to put all of the pieces in or do all of the treatments in order for things to work. And while I do love a good jigsaw puzzle, I got that from my mom, who's here in the audience tonight, thank you. That seemed too static for CF. CF has lots of moving parts and requires maintenance, more like a system of gears. Speaking of gears, let me introduce you to Lynne. Link is a metaphor to describe the complex systems that all connect with one another within the human body. Link will be making appearances throughout this plenary to help us take a look at what happens if a gear gets rusty and stops turning, and how can we keep the CF gears running efficiently as people with CF grow older. One example of how different systems are connected is posture. So let's take a look at what poor posture feels like and what, people sitting up a little bit straighter. Let's take a look at what poor posture feels like and what can result from poor posture. So I'd like everyone in the audience and those of you at home to slouch down in your seats. Let your hips slide to the front edge of your seat, hunch your spine forward, roll your shoulders in, drop your chin to your chest, keep it there. Take a breath in and out. And then you can sit back up with good posture, please. Remember what that felt like. We're gonna come back to it later. When our body isn't aligned correctly, first and foremost, our breathing is restricted. Additionally, our joints, muscles, and even internal organs can't function at their best. We then begin to see impairments such as pain, urinary incontinence, and fractures. These things may restrict ability and willingness to be active or to do airway clearance, which can lead to more lung infections. Then bring on the antibiotics. And with more exposure to aminoglycosides, people with CF may not experience just loss of hearing, but also vestibular impairments, feeling dizzy and off balance. When compounded with normal age-related changes, people with CF are at even higher risk for falls. PT-specific tests and measures to screen exercise capacity, strength, balance, and more will help guide personalized interventions to prevent and address these impairments. But we shouldn't wait until people are reporting these concerns. Mary Massery, a PT guru for all things pulmonary and neuromuscular, published this article back in 2005. She stressed the importance of early intervention, stating it's easier to prevent than to correct a postural problem. With CFTR modulators and other treatment advances allowing people to live longer, it's becoming much more apparent and important to intervene at a young age, to build strong muscles and bones, to address postural concerns and breathing mechanics, to establish healthy habits, to not only live longer, but to live stronger with a high quality of life. So to the pediatric clinicians in the audience, we may be talking about aging and growing older today, but so much of what allows people with CF to live into adulthood starts when they're in your care. Just like the gears of our friend Link working together, the multidisciplinary care team is interconnected to make sure people with CF are well cared for. It takes a team and good communication amongst the team to make sure all the moving parts of living with CF are well oiled. And while we're well versed in how the core members of the CF team work together, as people with CF grow older and we're seeing additional complications and comorbidities, the core team is compelled to partner with primary care providers and other specialists, which we'll hear about throughout this plenary. Last, but definitely not least, I want to highlight the main input gear on the team, the gear that gets the system started and keeps it going, the individual with CF. They are the expert that truly drives the machine that is their body and their care. The rest of us, the clinical team, are the supporting gears. It is so important for us as clinicians to listen and learn from the lived experience of the person with CF. So before Ahmet rejoins me on stage to grind through the gears of this talk, let's hear from the experts themselves about what it's like to grow older with CF.
One of the perks of aging with CF is that you have an abundance of doctors. I feel like I'm on one side of the fence, but CF puts me on the other side anyway. I'm like, I don't belong over here. My people are over there. My things, my stuff is over there. My life is over there. CF is like, no, you're here now. I'm trying to learn to be aged while also trying not to rule out what youth I do have available, you know?
I finish my treatments, I go to the gym, or I go to the pool, or I go out for a run. Definitely, as you age, your exercise has to change. And the medications we take weaken our tendons and our joints, can cause little minute fractures in bones. I used to be a runner who ran every day of the week. Now, if I run 2 days out of the week, that's it. It's a constant journey of discoveries with age. But aren't we lucky to have that? What I'm discovering is that this circle is actually becoming equally, if not more important than my clinic team. When I finally found a gynecologist who was qualified in cystic fibrosis, I was blown away. She opened my eyes to how, as a female with this disease, and now in menopause, how your world can be changed just by a doctor having that background. It wasn't until I found these trained gynecologists who got me on the right hormone therapy. That's when things changed for me. Oh my goodness. I mean, there's no looking back.
CF ages you in ways that aren't always so obvious. Sometimes they're subtle. You can't breathe, so you do less. And because you do less, your body stops responding when you need it to do things. It is a chain reaction. And everything you do, there's a give and a take. I was on tobramycin for a little while, and one of the side effects of that was hearing loss, which does not bode well for a musician. So we stopped taking it immediately. Ma! I got to go meet with the audiologist, but at first there was this, like, I don't know if it's because I'm just getting older. I don't know if it's just years of loud music. The unfortunate thing with hearing loss is that it too is progressive, and there's no like undoing. There's no reset button. So
I think what the clinic care teams need to know is we're not just CF. We're more than CF. We're more than the lungs, the pancreas, and the sinuses. We react to medications differently than the next CF patient. The clinic teams need to keep those open minds. Certain teachers had students write what they wanted to when I was leaving.
I find myself being okay with being greedier about life. At first it was like, I just want to be able to see, my niece and nephew and little brother graduate. And now I've watched all 3 of my siblings graduate. My nephew graduates this year, and now they're succeeding, and I'm like, I still want to be here for what's next.
I mean, we've watched that so many times, and each time it just touches us in a way like as if we're watching it for the first time. It's really amazing and truly brilliant. And thank you to Jen and Brandon to inviting us into your lives, into the places that you exercise, into listening to you jam, Brandon, and then also into your living rooms and in this Brandon's case, my dear friend Brandon, his bedroom. And in their own words, exemplifying the constant journey of discoveries with age. And it will be a really hard act to follow, but Karen and I are back here symbolizing the role of teams working together to slow down or stop inflammation. And we will follow this invisible thread of inflammation throughout this talk as we navigate through a small sample of body systems and impairments. These are critical as people age and the gears that can rust without proper attention.
And we hope this plenary helps foster conversation and collaboration across the care team and with other specialists.
So why is this topic important to us? We already showcased data on improving life expectancy, and we already have done so much to decelerate the aging process, but we have work to do since aging still is accelerated in CF. People living with complex illness offer a powerful window into how inflammation accelerates aging and even helps us understand the biology of aging itself. In CF, we see heart disease, kidney disease, and cancer appearing earlier, and is highlighted by a figure showing age and sex-adjusted rate ratios by our colleagues Rigia Arya and Ann Stevenson from Canada in a publication from this summer. We do need to remember that this study in large part was done before modulators. However, it is still important to note that people with CF may experience cardiovascular disease and cancer 20 years earlier, and if you've been transplanted, 30 years earlier.
So let's turn our attention to the leading cause of death in the general population, and previously one of the more underestimated gears in CF, the cardiovascular system. Just as inflammation drives pulmonary and gastrointestinal disease, it also causes wear and tear on our cardiovascular gear. Some examples shown here, once again, implicate persistent inflammation as it drives vascular aging. In addition to hypoxemia and sleep-disordered breathing, CFTR itself plays a role, with loss of function linked to abnormal vascular tone. CF-related diabetes is increasingly common and adds to cardiovascular risk. And the legacy CF diet, high fat, low fiber, may fuel dyslipidemia and metabolic syndrome.
And this may be confusing, but on the flip side, when you do get modulators, it is associated with increased number of people with high blood pressure, and there's an increased evidence of negative impact on lipids.
Yeah, and we're also seeing much higher rates of people who are overweight and obese. So again, we're seeing a gear that wasn't expected to turn this long, and it's starting to show signs of strain.
Yeah. I was having a conversation with our division chief, and he reminded me about lung function as it relates to the Framingham Heart Study, which has been following over 5,000 people and counting, and it's still going in Framingham, Massachusetts, for a long time, with an eye on cardiovascular outcomes and disease. And we all heard the messages of high blood pressure, smoking, cholesterol, and how it impacts cardiovascular disease. However, what we don't talk about and we bury is vital capacity or lung function and how it impacts and has an oversized role in cardiovascular risk, especially in women. So in this talk about everything other than the lungs, we want to make sure that you know the message is clear that we are still focused on maintaining the best lung function.
Yeah.
So, Karen, how do we protect that cardiovascular gear during the lifespan of someone with CF?
Well, it starts with screening, including annual lipid panels and blood pressure monitoring, especially for those with CF-related diabetes who are at higher risk, and regular diabetes screening for those without CFRD. In some cases, we might even consider stress testing and vascular imaging, such as coronary artery calcium scores, to catch early changes. And we need to work with primary care providers on more aggressive management.
Absolutely. Primary care providers are so critical. And it would be great to have a CF-specific cardiovascular risk score, and we're grateful that there are multiple groups that are working on this, including both here and overseas, and including a young investigator, Evan Manning, who's a cardiologist working with Alex Despotis, who you've seen her work, but she's not here because she just had a baby, and hopefully she's not watching and she's getting some sleep.
We also have other lubricants to support this gear. Nutrition is a powerful lever in controlling inflammation. And while we still need to support adequate caloric intake, we can do it with more heart-healthy strategies.
Yeah, there are foods that can be divided into those that are pro-inflammatory and those that reduce inflammation. So the great thing is, speak to your dietitian. You have one right there, to ensure people are minimizing the inflammatory foods they're intaking, including those rich in omega-6s, and eating more monounsaturated fats and foods that contain high amounts of fiber, omega-3s, polyphenols, which are compounds that come from plants. So while CFTR modulators may reduce systemic inflammation, improve insulin secretion and vascular function, there are medications like hormone therapies and also statins. Now, statins have high anti-inflammatory properties, and the American Diabetes Association recommends starting them if you're over the age of 40 and have diabetes, and that's not happening universally. Additionally, we know lifestyle is critical, and including, again, better sleep, reduction in stress, and of course, exercise.
I'm so glad you mentioned exercise. Exercise is a dual action lubricant here. It improves cardiovascular fitness and insulin sensitivity. Data show that even low to moderate activity can improve endothelial function, lower blood pressure, and regulate glucose metabolism.
Yeah, so the take-home message, cardiovascular disease is an outcome that is not inevitable, and screening is no longer optional in CF. So reduce inflammation through exercise and healthy eating, and the Mediterranean diet is a good example of how to combat heart disease. So thanks, Mom. I'm Mediterranean.
Possibly one of the most overlooked gears of CF is pain. It's a powerful disruptor and more common as we age, with significant negative impact on quality of life, mental health, and daily functioning. And those CFTR modulators can dial down inflammation. Pain prevalence and severity do not correlate with modulator use. A recent survey by Ward and others shows that up to 70% of adults with CF report chronic or recurrent pain, much higher than in people without CF. And the most commonly reported areas include headaches, joint and back aches, and GI pain.
Yeah, chronic pain is often hidden by stigma and bias. Too often it is brushed off as just infection-related and leaving patients to feel like they have to tough it out. And clinicians are hesitant to ask those questions. But pain is more than a symptom. It is its own dysfunctional gear and slowing movement, affecting sleep, mood, breathing, and treatment adherence. These are quotes from an editorial written by 3 people with CF, Noor, Cade, and Casey. Pain is awful, but being disbelieved is excruciating.
And if you haven't already, I would highly recommend you read that article. It truly sends a powerful message. The good news is, pain can be managed, and not just with medication. Like any gear under the stress of inflammation, it just needs the right lubrication, thoughtful, individualized, and multidisciplinary care. First, we have to actually look at it. Make pain assessment a routine part of clinic visits, not just when someone is sick. We need to identify patterns early. The newly published CF Foundation pain guidelines recommend routine screening with a PROMIS pain scale to capture both pain intensity and functional impact. For nonverbal adults, we have the observational FLAC scale. And there's also the very recognizable visual analog scale. Any level of endorsed pain should be followed with a comprehensive clinical assessment and appropriate interventions.
And we're broadening our pharmacological toolbox for pain and cystic fibrosis, moving towards a more balanced and multimodal approach. And depending on the source of the pain, there are a variety of options. While there are a role for medications, including opioids, medications alone, even just anti-inflammatories, are never the whole solution. They work as part of a broader multimodal pain management plan. So what else should that plan include?
Well, there's a lot more beyond medications, and movement is one of our most powerful tools. Regular, structured exercise can help prevent stiffness, preserve strength, improve mood, and reduce systemic inflammation. Even short activity snacks throughout the day can slow the pain gear. And when help is needed, this is where physical therapy can play a critical role. PTs can assess biomechanics, postural patterns, and muscle imbalances which may be contributing to pain.
I could really go for an activity snack. I am starving, I haven't eaten all day. And let's not forget about the role of mental health. People with CF who have chronic pain are more likely to experience emotional distress, which in turn amplifies pain perception. So mindfulness and relaxation techniques can lower that perception of pain and also help people manage flare-ups. Karen, you taught me this. Incorporating cognitive behavioral therapy along with acceptance and commitment therapy alongside physical rehab improves both pain and mental health. So improving sleep is also critical. Better rest raises pain thresholds and supports mental health.
And as we hear from people with CF, they don't expect the CF team to be experts in pain, but we should partner with them in solving it. And that may likely involve educating other specialists about CF. And the take-home message here, in short, pain is not just a symptom. It's a gear of its own and a byproduct of stress on the body over time. With early recognition and a maintenance crew of a team, we can reduce inflammation and get this gear moving again.
Yeah. Closely related to pain is another gear that is critical for our function and maintain our quality of life, and that's the musculoskeletal system.
Yeah, let's think of the bones and muscles as the foundation gears in the complex machine of the human body. Without a strong, stable musculoskeletal system, other gears, such as breathing, posture, pain, even glucose metabolism, cardiovascular health, and more, can't function properly. Let's start with muscles. Studies comparing adults with CF to healthy peers consistently show lower muscle power and reduced peripheral muscle strength, including lower hand grip force and weaker thigh muscles. These deficits can impact participation in daily life, respiratory performance, and overall survival.
CF-related bone disease is well-recognized complication, and it appears much earlier than in the general population. Data from the CF Foundation registry show that about 1 in 4 adults with CF have low bone mineral density, but some single-center studies show that it's almost 50%. And in the general population, about 30% of women over 65 have osteoporosis, but it is nearly 40% in women with cystic fibrosis. So the risk is even greater after transplant, unfortunately, where 45 to 73% of people experience bone loss, and the steepest loss of bone happens in that first year after transplant. So Karen, what's causing these changes to bone and muscle, your favorite topic?
Yeah, well, Ahmet, there are many causes of bone disease, and we'll speak to just a few of them tonight. CF-related diabetes, poor calcium intake, and malabsorption of vitamins D and K can slow down the musculoskeletal gears, and vitamin K is especially important for bone mineralization. Post-transplant, immunosuppressives and steroids lead the way. Estrogen deficiency, especially around peri and early menopause, lead to rapid loss of bone and muscle mass, and therefore increased fracture risk. Reduced physical activity is yet another contributor.
Yeah. And inflammation, once again, the culprit here.
Yet again.
Inflammation promotes bone loss by signaling bone breakdown and inhibiting the building of bone. And this occurs through a lot of different pathways. But one example is rankle, a newer pharmaceutical target that may not be appropriate for everyone, but when activated in the absence of CFTR, promotes muscle and bone breakdown.
And here's the encouraging part. We know how to maintain and even strengthen this gear at any age. But like any machine, it requires early investment, regular maintenance, and coordinated care. Muscle is one of the most adaptable tissues in the human body. First, in children, building muscle mass is critical. In this conceptual model, modified from Gruet and colleagues, we see what happens to muscle strength over time for people in the general population who participate in sports and have normal levels of physical activity. For people with CF to maintain close to that muscle strength, they need high levels of physical activity with resistance training and sport participation. And for those who are more sedentary with decreasing activity in the later decades, we see even steeper declines in muscle strength. So to sum up what is shown here, people with CF have an uphill battle and have to do more to build and maintain muscle strength.
So what do you suggest they do, Karen?
Well, I'm glad you asked.
Good.
Early resistance and functional training when young helps to maximize peak muscle mass, serving as a buffer for later years and also a strong predictor of peak bone mass, as well as lifelong mobility. In adulthood, programs should be tailored to match each person's baseline strength, fracture risk, motivation, and readiness to exercise. This includes resistance training, jumping exercises for those who are able, and posture correction to prevent vertebral stress. For individuals who are less active, have advanced lung disease, or are at higher risk for fractures, we can start with lower impact options and gradually build up.
Yeah, an individualized approach is best, and whatever you can do. And while we don't have any large studies specific to muscle and exercise outcomes from people taking CFTR modulators, there are some emerging randomized controlled trials. So Sosa Perdesky and others have showed that a remotely supervised resistance training program with moderate to high intensity improved lower limb muscle strength and body composition compared to those who didn't exercise. And then Clayton colleagues compared adults with CF taking ETI to healthy controls and found similar outcomes in terms of body composition and peripheral muscle mass function, suggesting that modulators enable muscles to catch up when paired with exercise.
Yep. And in addition to exercise and nutrition, early detection and monitoring of bone and muscle health is key. In the US, the median rate for DEXA, or bone density screening in CF, is 66%. We need to do better. Low bone mineral density is treatable. Newer tools such as vertebral fracture assessment and FRAC scores should be considered to help with risk prediction. Please refer to the Bone Disease Clinical Care Guidelines for more detailed information on screening and interventions. And for muscles, tracking body composition rather than weight and body mass index will help to guide discussions and assess if interventions are actually improving muscle mass.
And we need to broaden our CF team. We need to work with our pharmacists, as we do, our endocrinologists, gynecologists, and other team members to determine the best therapy or a combination of therapies based on an individual's risk. Pharmacologically, there are bisphosphonates, and there are CFTR modulators, as we learned, that help with bone density, as well as new biological pathways that go beyond hormone therapy. For example, recently published work by Petraglia on amino acid supplementation shows promising results on how to interrupt muscle mass loss and systemic inflammation. In the general population, creatine has shown benefits in aging populations for muscle strength, energy, and brain health. However, hidden and invisible kidney disease does occur in CF, so this is something we need to be cautious about.
Strong bones and muscles allow us to climb the stairs, carry groceries, play with our kids, and so much more. Our take-home message: with early investment, regular screening, ongoing maintenance, which includes inflammation management, and a coordinated team approach, we can keep this power gear turning smoothly, keeping the rest of the system in motion.
Now, we've seen how inflammation drives pain and musculoskeletal complications and how they all misalign our gears, disrupting everything from movement to mood to motivation. But behind the scenes, there's another system manipulating inflammation as well, and that's hormones.
Yeah. Hormones can have a significant impact on aging, particularly in the form of perimenopause and menopause in women and testosterone decline in men. These hormonal shifts affect many systems throughout the body. And while there's fluctuation of multiple hormone levels, we're going to focus on two today: estrogen and testosterone.
Chronic infections, inflammation, frequent use of glucocorticoids, and poor nutritional status all affect hormone deficiency in both men and women. CFTR dysfunction also plays a role. In women, CFTR dysfunction can lead to ovarian dysfunction. And age, which we can't stop, is another cause of declining hormone levels. For women, after surge during pregnancy, we see a steep decline in estrogen during perimenopause and menopause around age 50, and slightly earlier for women with CF. And testosterone decline also begins a bit earlier for men with CF and steadily declines as part of your aging process starting in your 40s and 50s.
Yeah. Symptoms of hormone deficiency for men include low libido, erectile dysfunction, infertility, and osteoporosis. Only about 1 in 10 men with CF have had their testosterone checked. And of those men, low testosterone is seen in about 1/3, with a median age of just 44 years.
And compare that to only 6 to 12% of men under the age of 60 in the general population. So younger age, middle-aged men with CF are showing rates similar to or even higher than people over the age of 60 without CF in the general population.
Yeah, and women may experience a wide variety of symptoms and symptom severity due to declining estrogen. And I think the women over 40 in the audience will agree with me about these symptoms, especially those from dinner Wednesday night.
Should have been invited. Should have been invited.
Sorry we didn't invite you. We've heard from women with CF, like Daniela, if you attended Symposium 4 yesterday, how they're unsure if these symptoms are due to CF, a reaction to a medication, low blood sugar, or aging and perimenopause.
And menopause is deservedly having its moment in our discourse. And is, of course, of great interest to us because it represents an opportunity to make a difference and to limit the impact of inflammation.
The menopausal transition and early post-menopause period represents a window of opportunity to preserve bone mass and prevent heart disease. Exercise, specifically focused on building muscle, is key during this time period, in addition to other therapeutic options, including hormone therapy for those who are eligible.
Yeah, whether we deliver it systemic, transdermal, or otherwise, when estrogen is present during perimenopause, it can have a positive long-term impact on bone density and muscle strength, as well as heart health and cognition.
We have the menopause-specific quality of life instrument to help with screening, in addition to the CFresh website, which has resources such as priority questions to help guide your discussions and then make the appropriate referrals.
Yeah. While in that process of referring a patient to that expert, you need to consider some potential risk factors in CF. Venous thromboembolic disease or blood clots, heart disease. A big no-no is liver and biliary disease and prostate cancer in men. And breast cancer and general cancer risk in women with hormone therapy made the headlines when the Women's Health Initiative first reported its findings in 2002 and based on the headlines of relative risk. But the absolute risk was actually quite small. However, we know CF's chronic inflammation raises other cancer risks, so the recommendation is for continued cancer screening and a treatment plan that's devised collaboratively with our expert partners.
Exercise, diet, and social connections are key for everyone, but especially if hormone therapy is not an option. There are also non-hormonal medications and cognitive behavioral therapy, which can help manage some of the symptoms.
So our take-home message for everyone: we need to screen for symptoms and refer to specialists to discuss best treatment options to address hormone deficiency and ultimately reduce inflammation for each individual.
As Ahmet mentioned before, people with CF can get cancer years earlier than others without CF. It isn't surprising that, yet again, chronic inflammation plays a critical role, and cancer is most prevalent where inflammation exists. We're seeing many different types of cancer. Some are directly related to CF, while others are influenced by age or age-related conditions. The higher rates of GI cancers, for example, tie back to gastroesophageal reflux disease, bowel inflammation, and diabetes, leading to oxidative stress and DNA damage. Risk is further increased when we add in impaired mucosal barriers, changes in the gut microbiome, bowel obstruction, altered immune responses, and perhaps lifestyle factors, such as that high-fat, low-fiber diet, vitamin D deficiency, and low levels of activity. So Ahmet, what else is driving this elevated cancer burden?
Yeah, that's $1 million question. CFTR dysfunction is associated with multiple pathways of increased cancer risk, and whether CFTR modulators reverse this is still yet to be determined. It also drives inflammation, increasing cytokines and chemokines, altering signaling pathways and increasing pathways like TGF-beta, beta-catenin, and NF-kappa B. So when CFTR functions normally, it actually acts as a tumor suppressor gene. One of its roles is maintaining epithelial integrity and inhibiting something called epithelial mesenchymal transition, or EMT. However, dysregulation of EMT is what contributes to cancer being more aggressive or spreading by enabling epithelial cells to lose polarity, lose that cell-cell adhesion, and acquire mesenchymal traits, or in other words, characteristics of the surrounding tissue. And essentially, they blend in and they gain migratory and invasive capabilities. These characteristics are what's essential for tumor progression, invasion, and metastasis. So even when a tumor from someone who doesn't have CF acquires a CFTR mutation, that tumor becomes more aggressive or malignant. Low CFTR expression in tumors correlates with advanced stage disease, lymph node metastasis, and poor prognosis. So add in transplant-related immunosuppression, which impairs tumor surveillance, and this gear becomes especially vulnerable.
But the good news is, we have the tools to keep the cancer prevention gear moving, but only if we use them early, consistently, and equitably. Many people still think of cancer as something that happens later or to other people, but the data support the exact opposite.
So the number one message is screening. And if you listen to Conan O'Brien like I do, he loves a good colonoscopy.
Don't we all?
The CF Foundation currently recommends colonoscopy starting at age 40 or age 30 for those who had had a transplant, and of course consider earlier screening or other risk factors or concerning symptoms if other concerning symptoms are present. You need to repeat screening every 5 years or based on findings more frequently.
In a 2022 registry review, less than 25% of eligible adults with CF had undergone colorectal cancer screening. Today, the numbers screened, and therefore those avoiding cancer, are increasing. However, they are still not high enough at only 43%.
This is not negotiable, people. We must do better, and colonoscopy has been shown to reduce mortality in this population. So at our center, Steve Friedman, when he finds and removes a precancerous polyp, it's a cause for celebration because we know we avoided another case of colorectal cancer. And we are grateful to the NICE-CF team to share their results with us, and you may have seen them report their results. And in the largest study of its kind, they evaluated whether non-invasive stool testing predicts findings of polyps or colon cancer. While non-invasive stool testing was preferred, I get that, to colonoscopy, they are not recommending stool studies due to this high false negative rate and poor correlation with colonoscopy findings.
Here's a summary of recommendations beyond colonoscopy. Cancer is no longer an abstract future threat. It's part of the present-day experience of living longer with CF. And bringing that gear into focus is part of comprehensive, forward-thinking CF care. This means ensuring people are getting their mammograms and testicular exams, as well as age-related screens for skin and prostate cancer.
And for those with chronic immunosuppression, we need to screen even earlier. And additionally, screen for things like lymphoma and HPV-related cancer. So dermatologic exams, pap smears, and even prevention with the HPV vaccine are really important not to forget. And also see our pancreatic cancer screening improvement project on poster 724. So we need to talk openly about cancer risk, including obtaining a good family history, maybe something we weren't doing so as much before. And remember, family members who are carriers of the CFTR mutation are also at increased risk, slightly increased risk of cancer as well, compared to the general population. So the take-home message, comprehensive screening is important. We need to target inflammation and modify those risk factors for developing cancer.
And please, don't forget to recommend exercise to both mitigate cancer risk and help improve outcomes for those with cancer. Today, we've covered just a handful of the gears that drive growing up and growing older with CF. Yet there are so many others we just couldn't get to in our limited time up here.
And we didn't forget about hearing loss, Angie and Ron. It's definitely a topic we need to address and needs more attention for sure.
Yeah, it's really a lot. So let's take a moment for a breather. By this point, hopefully you've seen the importance of a healthy, active lifestyle. So how about we all get moving together? To those of you watching at home, please join in. I'd like everyone to come forward to the front edge of your seat and put both feet flat on the floor.
I'm gonna use the word posture.
Think back to that breath you took earlier with slumped posture and remember how it felt. Now I'd like everyone to lift their chest, roll your shoulders back and down, and take a nice big slow breath in and out. Easier than with slumped posture? Now let's add some movement. With elbows at your sides and palms facing up, take a breath in as you rotate your hands out and squeeze those shoulder blades together. We're all family here, it's okay. And then bring your hands back in as you blow out.
Hopefully they're
Let's do one more, okay? So elbows at your sides, chest is lifted, rotate hands out as you breathe in, and then out. Feels good to move, right? It's been a long day.
Yeah, that feels good.
We're not done yet.
Yeah, I also thought we were done. So to recap, We briefly mentioned those 4 themes that we talked about earlier for today and how to reduce inflammation, to decelerate aging, and prevent or delay complications related to growing older. And there is lifestyle interventions, cells and immunity, genes and proteins, medicines and vaccines. And a message for everyone, providers, scientists, people with CF, make sure to exercise, reduce stress, and get plenty of sleep to keep those telomeres fresh.
We encourage you, we're not done, wait. We're close, I promise.
We're teasing you.
We encourage you to form relationships with local specialists, such as menopause experts, and welcome them to become authorities in their field for people with CF. Once they join the CF community, they will likely find it deeply rewarding and quickly grow to love working with this population like we all do.
And that I've seen that happen. We need to expand that next generation of providers, including with amazing programs sponsored by the Cystic Fibrosis Foundation like Digest, Envision, and PACE, just to name a few. In addition to initiatives sponsored by the CF Foundation, there are other organizations are also doing their part, like CFRI and the Nash Family Foundation-sponsored Pat Nash Fellows Program.
Yeah, and I've been listening to this podcast about aging with CF. Can you tell us more about that?
You listen?
I listen. Don't leave me
That's so
hanging.
great. Well, there's a grassroots podcast called It's a Long Story, and it's dedicated to people and topics about growing older, and it is produced and co-hosted by people with CF. So visit itsalongstory.com, and we welcome your ideas, and maybe we'll have you on as a guest.
It's pretty good. It's worth listening to. While trends and data...
Thank you for allowing me.
While trends and data from the larger CF community are extremely beneficial, it is still about the care team partnering with each individual. Practicing good communication to build and maintain relationships is of the utmost importance.
And respecting and trusting each other allows for those gears to keep turning. Trust does not mean we have to think the same way or have the same opinions, but trust is honoring the person with CF as a decision maker. It's listening without judgment and respecting them as an expert.
Yeah. A quote from one of the experts about aging. The question with me is, at 77 years old, are we dealing with CF? Are we dealing with age? Are we dealing with both of them? Or does CF make the age process worse? We need to work with each individual to learn about their unique experience with aging. So ask your patients, what's changing in their lives? They know their bodies better than anyone else. Ask about what new symptoms they're experiencing and what do they think is the cause. Ask about their expectations for care, and most importantly, ask how the changes are making them feel.
We need to stay curious and not judgmental. We need to ask about what it's like growing older and truly listen, like Brandon said.
Finally, we need to continue to do what we do best as a CF community. We need to stay ahead of the curve, which again involves forming relationships with experts beyond that core team.
And to always remember the words of our dear friend of the CF community, Francis Collins. We have within our grasp the ability to alleviate suffering and improve quality of life. That must be our mission, not just adding years, but adding meaning to years.
So let's keep the gears turning on growing older with CF.
Together.
Side by side.
As one team. Good night, Seattle.